Question 1. A 72-year-old client with heart failure is admitted with increasing dyspnea and 3+ pitting edema to the lower extremities. The client has gained 3 kilograms, 6.6 pounds, in 4 days. Current prescriptions include furosemide 40 milligrams IV twice daily. Which assessment finding requires immediate intervention? A. Serum potassium 3.4 milliequivalents per liter. B. Crackles in bilateral lung bases. C. Urine output 45 milliliters per hour. D. Blood pressure 102/64 millimeters mercury. Answer B. Crackles in bilateral lung bases. Rationale: crackles indicate worsening pulmonary fluid accumulation and possible pulmonary edema. Airway and breathing take priority, ABCs. While potassium of 3.4 is mildly low, it is not immediately life-threatening. Urine output of 45 milliliters per hour is adequate. BP 102/64 is acceptable in heart failure. Pulmonary edema can rapidly compromise oxygenation and requires urgent action. Question 2. A client with diabetic ketoacidosis, DKA, is receiving IV insulin and 0.9% normal saline. The nurse notes the following laboratory results. Sodium, 148 milliequivalents per liter. Potassium, 5.8 milliequivalents per liter. Glucose, 620 milligrams per deciliter. Bicarbonate, 10 milliequivalents per liter. Which electrolyte imbalance should the nurse anticipate occurring first after insulin therapy is initiated? A. Hypernatremia. B. Hypokalemia. C. Hypercalcemia. D. Hypermagnesemia. Answer B. Hypokalemia. Rationale: insulin drives potassium into the cells. Although initial potassium is elevated due to acidosis and cellular shift, once insulin is administered, serum potassium can drop rapidly, leading to hypokalemia and life-threatening dysrhythmias. Continuous cardiac monitoring is required. Question 3. A client receiving continuous nasogastric suction develops muscle weakness and shallow respirations. Arterial blood gas results show pH 7.49, PaCO2 46 millimeters mercury, HCO3 minus 34 milliequivalents per liter. Which interpretation is correct? A. Respiratory alkalosis. B. Metabolic alkalosis with compensation. C. Metabolic acidosis. D. Respiratory acidosis. Answer B. Metabolic alkalosis with compensation. Rationale: elevated pH indicates alkalosis. Elevated bicarbonate indicates metabolic cause. PaCO2 is elevated as compensation, hypoventilation. NG suction removes gastric acid, causing metabolic alkalosis. The respiratory system compensates by retaining CO2. Question 4. A client with severe hyponatremia, Na plus 118 milliequivalents per liter, is confused and having tonic-clonic seizures. Which prescription should the nurse implement first? A. Restrict fluids to 1,000 milliliters per day. B. Administer 3% hypertonic saline IV. C. Administer oral sodium tablets. D. Initiate seizure precautions only. Answer: B. Administer 3% hypertonic saline IV. Rationale: severe symptomatic hyponatremia, less than 120 milliequivalents per liter with seizures, requires immediate hypertonic saline to prevent cerebral edema and brain herniation. Fluid restriction alone is insufficient during active neurologic compromise. Question 5. A client with chronic kidney disease has the following labs: potassium, 6.6 milliequivalents per liter, ECG, peaked T waves, creatinine, 4.2 milligrams per deciliter. Which medication should the nurse prepare to administer first? A. Sodium polystyrene sulfonate. B. IV calcium gluconate. C. Furosemide. D. 0.9% normal saline. Answer: B. IV calcium gluconate. Rationale: calcium gluconate stabilizes the cardiac membrane and protects against lethal dysrhythmias. It does not lower potassium, but prevents arrhythmias. This is the immediate life-saving intervention in hyperkalemia with ECG changes. Question 6. A client with SIADH has a serum sodium of 122 milliequivalents per liter. Which assessment finding is most concerning? A. Dry mucous membranes. B. Bounding pulse. C. Confusion and irritability. D. Increased urine output. Answer: C. Confusion and irritability. Rationale: SIADH causes dilutional hyponatremia leading to cerebral edema. Neurologic changes, confusion, irritability, and seizures indicate worsening cerebral swelling and require urgent intervention. Urine output is typically decreased, not increased. Question 7. A client receiving massive blood transfusion develops numbness around the mouth and muscle twitching. Which electrolyte imbalance is most likely? A. Hyperkalemia. B. Hypocalcemia. C. Hypernatremia. D. Hypomagnesemia. Answer: B. Hypocalcemia. Rationale: citrate in stored blood binds calcium, causing acute hypocalcemia. Manifestations include perioral numbness, tetany, muscle twitching, and prolonged QT interval. Question 8. A client with prolonged vomiting presents with the following labs: pH 7.51, HCO3 minus 36 milliequivalents per liter, PaCO2 48 millimeters of mercury. Which clinical finding supports this imbalance? A. Deep rapid respirations. B. Bradycardia. C. Hypoventilation. Or D. Kussmaul respirations. Answer: C. Hypoventilation. Rationale: vomiting causes metabolic alkalosis, loss of gastric acid. The body compensates via hypoventilation to retain CO2 and lower pH. Question 9. A client with hyperkalemia has peaked T waves and widening QRS complexes. Which order should the nurse question? A. Administer IV regular insulin. B. Administer IV calcium gluconate. C. Administer potassium chloride IV. Or D. Administer sodium bicarbonate. Answer: C. Administer potassium chloride IV. Rationale: potassium chloride would worsen hyperkalemia and increase risk of fatal dysrhythmias. All other options help shift potassium intracellularly or stabilize the myocardium. Question 10. A client with third spacing due to pancreatitis has hypotension and tachycardia. Which fluid is most appropriate initially? A. D5W. B. 0.45% saline. C. 0.9% normal saline. Or D. 3% saline. Answer: C. 0.9% normal saline. Rationale: isotonic fluids expand intravascular volume and treat hypovolemia. Hypotonic or hypertonic solutions are inappropriate in acute volume depletion. Question 11. A client receiving loop diuretics develops flattened T waves and U waves on ECG. Which electrolyte imbalance is suspected? A. Hyperkalemia, B. Hypokalemia, C. Hypercalcemia, or D. Hypernatremia? Answer: B. Hypokalemia. Rationale: loop diuretics cause potassium loss. ECG changes include flattened T waves and U waves. Severe hypokalemia can lead to ventricular dysrhythmias. Question 12. A client with severe hypernatremia, sodium 160 milliequivalents per liter, is lethargic. Which intervention is priority? A. Rapid correction with 3% saline. B. Administer hypotonic IV fluids slowly. C. Restrict fluids. Or D. Administer sodium tablets? Answer: B. Administer hypotonic IV fluids slowly. Rationale: hypernatremia must be corrected gradually using hypotonic fluids, such as 0.45% saline or D5W. Rapid correction risks cerebral edema. Question 13. Which assessment finding is most consistent with hypomagnesemia? A. Decreased deep tendon reflexes. B. Lethargy. C. Positive Schwastik sign. D. Bradycardia. Answer: C. Positive Schwastik sign. Rationale: hypomagnesemia increases neuromuscular excitability, causing tremors, tetany, and positive Schwastik or Trousseau signs. Question 14. A client in metabolic acidosis has Kussmaul respirations. What is the purpose of this breathing pattern? A. Retain CO2. B. Excrete bicarbonate. C. Decrease hydrogen ions. D. Blow off CO2. Answer: D. Blow off CO2. Rationale: Kussmaul respirations are deep, rapid breaths that reduce CO2 to compensate for metabolic acidosis and raise pH. Question 15. A client with hypercalcemia reports constipation and weakness. Which ECG finding is expected? A. Prolonged QT interval. B. Shortened QT interval. C. Peaked T waves. D. U waves. Answer: B. Shortened QT interval. Rationale: hypercalcemia shortens the QT interval and can lead to heart block or ventricular arrhythmias. Question 16. A client with burns covering 40% TBSA is at risk for which early electrolyte imbalance? A. Hypokalemia. B. Hyperkalemia. C. Hypercalcemia. D. Hyponatremia. Answer: B. Hyperkalemia. Rationale: cellular destruction releases intracellular potassium into circulation, causing early hyperkalemia. Question 17. A client receiving TPN develops confusion and a serum sodium 128 milliequivalents per liter. What is the most likely cause? A. Excess free water. B. Potassium deficit. C. Hypertonic dehydration. D. Respiratory alkalosis. Answer: A. Excess free water. Rationale: dilutional hyponatremia can occur if excess free water is administered with TPN. Question 18. A client has ABG, pH 7.28, PaCO2 52, HCO3 negative 25. Interpretation: A. Metabolic acidosis. B. Respiratory acidosis. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: B. Respiratory acidosis. Rationale: Low pH, acidotic, with elevated CO2 indicates respiratory acidosis. Bicarbonate is normal, indicating no compensation yet. Question 19. A client with hypophosphatemia is at risk for which complication? A. Muscle weakness and respiratory failure. B. Tetany. C. Seizures from cerebral edema. D. Shortened QT interval. Answer A. Muscle weakness and respiratory failure. Rationale: phosphate is essential for ATP production. Severe deficiency causes diaphragmatic weakness and respiratory failure. Question 20. Which IV fluid is most appropriate for cerebral edema? A. 0.9% saline. B. 0.45% saline. C. D5W. D. 3% hypertonic saline. Answer D. 3% hypertonic saline. Rationale: hypertonic saline pulls fluid from brain tissue into the intravascular space, reducing cerebral edema. Question 21. A client with severe diarrhea for 4 days presents with BP 88/54 mm mercury, HR 124 beats per minute, and urine output 15 milliliters per hour. Which acid-base imbalance is most likely? A. Metabolic alkalosis. B. Respiratory acidosis. C. Metabolic acidosis. D. Respiratory alkalosis. Answer C. Metabolic acidosis. Rationale: severe diarrhea causes loss of bicarbonate from the GI tract, resulting in metabolic acidosis. Hypotension and tachycardia indicate volume depletion. Question 22. A client with hypermagnesemia secondary to renal failure develops diminished deep tendon reflexes and bradycardia. Which medication should the nurse anticipate? A. IV potassium chloride. B. IV calcium gluconate. C. Sodium bicarbonate. D. Furosemide. Answer B. IV calcium gluconate. Rationale: calcium antagonizes magnesium at the neuromuscular junction and cardiac tissue, reversing cardiac and neuromuscular depression. Question 23. A client with hyponatremia has a sodium level of 124 milliequivalents per liter. Which intervention is appropriate if the client is asymptomatic? A. Rapid IV hypertonic saline. B. Fluid restriction. C. Immediate dialysis. D. Administer D5W. Answer B. Fluid restriction. Rationale: mild, moderate asymptomatic hyponatremia is managed with fluid restriction. Rapid correction risks osmotic demyelination syndrome. Question 24. A client with metabolic alkalosis secondary to diuretic use is expected to have which potassium level? A. Elevated. B. Decreased. C. Normal. D. Critically elevated. Answer B. Decreased. Rationale: loop and thiazide diuretics cause potassium loss. Hypokalemia commonly accompanies metabolic alkalosis. Question 25. A client with crush injury develops potassium 6.9 milliequivalents per liter. Which intervention lowers serum potassium most rapidly? A. Sodium polystyrene sulfonate. B. IV insulin with dextrose. C. Loop diuretics. D. Hemodialysis. Answer B. IV insulin with dextrose. Rationale: insulin rapidly shifts potassium intracellularly. Dialysis removes potassium but is not the fastest immediate action. Question 26. A client receiving hypotonic IV fluids develops headache, confusion, and nausea. What is the priority action? A. Slow the infusion. B. Stop the infusion. C. Increase rate. D. Add potassium. Answer. B. Stop the infusion. Rationale. Hypotonic fluids can cause cerebral edema. Neurologic changes indicate fluid shifting into brain cells. Stop infusion immediately. Question 27. Which ABG reflects fully compensated metabolic acidosis? A. pH equals 7.36, PaCO2 equals 30, HCO3 minus equals 18. B. pH equals 7.28, PaCO2 equals 30, HCO3 minus equals 15. C. pH equals 7.50, PaCO2 equals 48, HCO3 minus equals 35. D. pH equals 7.30, PaCO2 equals 55, HCO3 minus equals 26. Answer. A. pH equals 7.36, PaCO2 equals 30, HCO3 minus equals 18. Rationale. pH is normal, but low normal. Low HCO3 minus indicates metabolic acidosis. Low PaCO2 indicates respiratory compensation. Question 28. A client with hyperphosphatemia is most at risk for which secondary imbalance? A. Hyperkalemia. B. Hypocalcemia. C. Hypermagnesemia. D. Hypernatremia. Answer. B. Hypocalcemia. Rationale. Phosphate binds calcium, lowering serum calcium levels. Question 29. Which assessment finding is expected in hypovolemia? A. Bounding pulse. B. Hypertension. C. Cool, clammy skin. D. Decreased hematocrit. Answer. C. Cool, clammy skin. Rationale. Hypovolemia causes vasoconstriction, tachycardia, hypotension, and cool, clammy skin. Hematocrit is often elevated due to hemoconcentration. Question 30. A client with respiratory alkalosis from hyperventilation will likely have which symptom? A. Hyperkalemia. B. Dizziness and paresthesia. C. Bradycardia. D. Warm, flushed skin. Answer. B. Dizziness and paresthesia. Rationale. Respiratory alkalosis causes decreased CO2, leading to cerebral vasoconstriction, dizziness, and tingling. Question 31. A client with SIADH has urine-specific gravity 1.035. What does this indicate? A. Dilute urine. B. Concentrated urine. C. Renal failure. D. Diabetes insipidus. Answer. B. Concentrated urine. Rationale. SIADH causes excessive ADH, leading to water retention and concentrated urine. Question 32. A client with hypocalcemia develops stridor. What is the priority intervention? A. Oral calcium. B. Seizure precautions. C. IV calcium gluconate. D. Fluid restriction. Answer. C. IV calcium gluconate. Rationale. Stridor indicates laryngospasm, a life-threatening complication of hypocalcemia. Immediate IV calcium is required. Question 33. A client receiving potassium IV complains of burning at the site. What is the best action? A. Stop infusion. B. Slow the rate. C. Apply heat. D. Flush with saline bolus. Answer. B. Slow the rate. Rationale. Potassium is irritating to veins. Slowing the infusion reduces irritation. Ensure it is properly diluted. Question 34. Which finding indicates fluid volume excess? A. Flat neck veins, B. Hypotension, C. S3 heart sound, D. Decreased weight. Answer: C. S3 heart sound. Rationale: an S3 indicates ventricular overload and fluid volume excess. Question 35. A client with hypokalemia is at risk for which imbalance? A. Hyponatremia, B. Hyperkalemia, C. Hypernatremia, D. Hypermagnesemia. Answer: C. Hypernatremia. Rationale: excess water loss without sodium loss leads to hypernatremia. Question 36. A client with metabolic acidosis secondary to renal failure may receive which medication? A. Sodium bicarbonate, B. Potassium chloride, C. Calcium channel blocker, D. 3% saline. Answer: A. Sodium bicarbonate. Rationale: bicarbonate may be administered to correct severe metabolic acidosis. Question 37. A client with hypokalemia is receiving digoxin. What is the concern? A. Decreased digoxin effect, B. Increased risk of digoxin toxicity, C. Hypercalcemia, D. Hypertension. Answer: B. Increased risk of digoxin toxicity. Rationale: low potassium enhances digoxin binding to cardiac cells, increasing toxicity risk. Question 38. Which finding is associated with hypernatremia? A. Seizures, B. Muscle weakness, C. Dry, sticky mucous membranes, D. Positive Trousseau sign. Answer: C. Dry, sticky mucous membranes. Rationale: hypernatremia causes cellular dehydration, leading to dry mucous membranes and thirst. Question 39. A client with respiratory acidosis will most likely have which cause? A. Diarrhea, B. Panic attack, C. COPD exacerbation, D. Vomiting. Answer: C. COPD exacerbation. Rationale: hypoventilation leads to CO2 retention and respiratory acidosis. Question 40. Which electrolyte imbalance causes peaked T waves? A. Hypokalemia, B. Hyperkalemia, C. Hypocalcemia, D. Hypernatremia. Answer: B. Hyperkalemia. Rationale: peaked T waves are classic for elevated potassium. Question 41. A client receiving 3% saline requires which monitoring? A. Blood glucose, B. Serum sodium, C. Platelet count, D. INR. Answer: B. Serum sodium. Rationale: hypertonic saline can cause rapid sodium shifts. Frequent monitoring prevents osmotic demyelination. Question 42. Which electrolyte imbalance causes prolonged QT interval? A. Hypercalcemia, B. Hypocalcemia, C. Hyperkalemia, D. Hypernatremia. Answer: B. Hypocalcemia. Rationale: low calcium prolongs ventricular depolarization, lengthening QT interval. Question 43. A client with fluid overload develops crackles and dyspnea. Which medication is anticipated? A. Mannitol, B. Furosemide, C. Desmopressin, D. Potassium supplement. Answer: B. Furosemide. Rationale: loop diuretics remove excess fluid and relieve pulmonary congestion. Question 44. A client with hypomagnesemia is at risk for which rhythm? A. Torsades de Pointe, B. Sinus bradycardia, C. Atrial flutter, D. First-degree AV block. Answer A. Torsades de pointe. Rationale: low magnesium predisposes to ventricular dysrhythmias, especially torsades. Question 45. A client with hypercalcemia may exhibit A. Hyperactive reflexes, B. Tetany, C. Constipation, D. Seizures. Answer C. Constipation. Rationale: hypercalcemia slows neuromuscular activity, causing constipation and weakness. Question 46. A client with severe dehydration has hematocrit 56%. This indicates A. Hemodilution, B. Hemoconcentration, C. Anemia, D. Infection. Answer B. Hemoconcentration. Rationale: fluid loss concentrates red blood cells, increasing hematocrit. Question 47. Which IV solution is isotonic? A. 0.45% saline, B. D5W, initially isotonic but acts hypotonic, C. 0.9% saline, D. 3% saline. Answer C. 0.9% saline. Rationale: normal saline remains isotonic within the intravascular space. Question 48. A client with alkalosis may develop which potassium imbalance? A. Hyperkalemia, B. Hypokalemia, C. Hypernatremia, D. Hypermagnesemia. Answer B. Hypokalemia. Rationale: in alkalosis, potassium shifts intracellularly, lowering serum potassium. Question 49. A client with severe metabolic acidosis is breathing rapidly and deeply. This is called A. Cheyne-Stokes, B. Biot respirations, C. Kussmaul respirations, D. Apneustic breathing. Answer C. Kussmaul respirations. Rationale: deep, rapid breathing compensates for metabolic acidosis by eliminating CO2. Question 50. A client with fluid volume deficit should have which priority intervention? A. Fluid restriction, B. IV isotonic fluids, C. Hypertonic saline, D. Diuretics. Answer B. IV isotonic fluids. Rationale: isotonic fluids restore circulating volume without shifting fluid into cells. Congratulations! You've completed all 50 high-yield fluid and electrolyte NCLEX questions. Remember, mastering electrolytes, ABG interpretation, and priority labs is essential for passing the NCLEX with confidence. If you found this video helpful, smash that like button and subscribe to MCQs Master 101 for more exam-focused NCLEX practice every week. Pro tip, rewatch any questions you got wrong and make your own flashcards. Repetition is the key to NCLEX success. Comment below your toughest fluid and electrolyte question and I'll review it in the next video. Thanks for studying with me. Let's crush the NCLEX.